Hi, I'm Ron Lang, the Chief Executive Officer of CalCPA Health. We provide health benefits for CPA firms in the state of California. Today's topic is employee benefits or managing employee benefits for CPA firms. We want to share some ideas and things that we hear about in the market and give some ideas on managing your benefit plans in this ever-changing environment. Throughout the broadcast, you can click on the Ask the Instructor tab and ask questions, and if we can answer them during the broadcast, we will, and if not, we'll try to get back with you afterwards and get you an answer. We also maintain a employee benefits hotline at CalCPA Health, and we take emails and phone questions outside of this broadcast also. So for today's agenda, we're going to be talking about some topics of managing employee health plans, common health plan issues and topics that we run into on a regular basis, and how you may help your employees through those situations. We want to talk about some difficult situations that you run into in employee benefit plans, and then some trends that you can follow along or get ahead of in the market. And then we'll wrap things up with what we're calling the ever-changing regulations. Although most of Obamacare is fully implemented, the various government agencies still are tinkering with things and changing things around. And so we'll talk about the regulation changes that are coming in 2018 and a couple comments about Obamacare Sustainability. We'll start off with, usually at CalCPA Health, we always say jokingly that we don't give tax advice here at CalCPA Health because all of our CPA clients can handle that. But today we are going to be touching upon some areas of employee benefit law and regulations. And these laws vary by size of firm, state, county, and city regulations, and they change all the time. So any takeaways from this, if you or your firm are going to put something in place or take action, please check with your benefit experts or attorneys in that area to make sure that you do it properly. So we'll move right into common complaints or issues. Sometimes they're issues, sometimes they're complaints that employees are having with their health plans. So historically, if we were having this discussion a couple of years ago, the kinds of things that we'd be hearing were really related to prescription drugs. So an employee would walk into the pharmacy and the pharmacist would say, your drug is not covered by your plan. And of course that creates an issue and a complaint. The other area was in mandatory generic substitutions. So with generic substitutions, that means that it's the same exact ingredient of the drug. And it's taken a while for that to get disseminated throughout the population, that if your doctor writes you a prescription for, say, Lipitor, and you get a prescription for generic Lipitor, it's the exact same ingredient. Now, there are substitute drugs that are not generics, and that's a little bit different situation. But if your pharmacist says, I'm giving you a generic substitution, it's the exact same ingredient as in the brand name drug, there's no differences. Well, why is this complaint kind of subsided a little bit? Well, people have gotten used to the controls that are placed on drug programs, but also the pharmacists and the doctors are handling it better and they've figured it out. Nowadays, instead of the pharmacist saying your drug's not covered by the plan, a lot of times they'll say, I need to contact your doctor or your plan, because they need to get an authorization and they need to find out why it's not covered or a substitute or a generic that'll do the job. And all those communications between the doctor, the pharmacist, and the pharmacy benefit management company or the health insurance company are all handled by email and website communications very efficiently nowadays. So you walk into the pharmacy, the pharmacist needs to get an authorization, they send a note to either the pharmacy benefit management company or the doctor. The doctor goes on a portal, submits the backup documentation, it's approved, could be within an hour, could be half a day, and you've got your drug and you're off and running. So that problem has gone away in part through technology and in part through people getting used to working with the system. Another area is slow claim payments. Nowadays, most doctors and hospitals are e-billing and receiving e-payments. I believe every hospital in the state of California that does business with Anthem and with Blue Shield, who are the two largest providers, are required to do e-billing. So at CalCPA Health, we turn around most of our typical claims in 1 to 3 weeks. And in fact, most claims are turned around the week that we get them. Now, we always have to put the disclaimer on there that it's a typical claim. If a large hospital claim comes in and it needs to be evaluated or audited before it can be paid, of course, the timeline starts extending out. But nowadays, most claims are adjudicated within a week or two, and most are instantaneous. I just want to note on these quicker claim turnarounds. So there are inherent issues, and we're going to talk about HSA plans later in this class. There are inherent issues with Hsa Accumulator time lags, and what I mean by that is you go into the doctor and you incur some claims dollars, and then the next day or that afternoon you go to a pharmacy and you get a prescription, which is a very common occurrence. Well, the accumulators on your HSA account can't catch up with that scenario. In the old days, that time lag could be days or weeks as the claims are processed. As the technology's gotten faster, it doesn't completely eliminate, but it certainly taps down a lot of the HSA accumulator time lag issues. And then, of course, the ACA has put in some regulations around claim turnaround times. The state of California has regulations around claim turnaround times. So for today, so that was a historical view on what we've been seeing that have kind of alleviated themselves. So what are we seeing today? And the number one is out-of-network provider charges. So what are out-of-network provider charges? They are non-participating doctors, hospitals, and facilities. In the industry, we call them non-par. So non-par, out-of-network doctors, same type of thing. There are two types of those. So one type is known non-par providers. So you go to an outpatient surgery center, you're going to have laser spine surgery, you know that the doctor is out of network, you've made that decision, and you're going to have that done. Or you're going to have some test. Popular ones are the MRIs. So the MRIs that you hear about on the radio, where they're going to do the full body scan, and you know that it's non-network, and you go in and you pay for that on a non-network basis. Then there's the area which I call the surprise non-pars, and those are where you didn't know that the doctor or the hospital or the laboratory was a non-par provider, a non-network provider. This typically happens in laboratories and other ancillary services. Anesthesiologists are very common in this area, and then when a specialist is called in. So you're seeing your doctor, and they want you to consult with the specialist across the hall. And so they either go get the specialist or they send you across the hall, and when you walk into that specialist's office, they're a non-par provider, and you get socked with a big bill. So those are the areas that we see the non-participating providers in. So we'll move into kind of some of the scare tactics here, or real-life examples of non-par claims. And this is a clip from a bill from an outpatient surgery center. And you can see that if this was a non-network provider, that the patient would have been billed the $17,000, but because it was in network, an 89% PPO discount was applied, and so the amount that was owed on this bill was $19,000. Now this is happens to be before insurance, and most of this amount is applied to a deductible. So this is the EOB, the explanation of benefits that related to that provider's bill, and I just wanted to show that those totals, or that the detail that comes up to those totals, not that you're going to look at the details, but if you look up in the upper right-hand corner, it says it is not your responsibility to pay that $15,000 because you went to a network provider. So I think everybody realizes the value of going to a network provider. I just want to zoom in on the bottom here to show those totals. And then another, this is also an outpatient surgery bill. This is a non-net, so we just showed one, a $17,000 bill from a network provider. This is a non-network provider. It was an outpatient surgery. The non-network provider billed $104,000. $99,000 of that was excluded. The patient was back billed $99,000 for this procedure. So why is this trending upward? Why are we having these non-network claims? Well, there's a number of market forces at work here, and it's mostly for specialists. Specialists are in high demand, and so they can, in essence, charge more than what the network contracts are paying. They don't like to comply with utilization controls, and a lot of these specialties have utilization controls. And so when they're doing treatments that might not be considered medically necessary or alternative treatments, once again, I'll mention just some of these laser spine surgeries or some alternative therapies, they're not considered medically necessary, or they may be experimental, and so they're happening on a non-network basis. If a doctor has a practice and their waiting room is full of people, they can charge a higher rate, and we see certain specialties doing that. The dollars involved can be staggering. As medical inflation has continued upward, the examples that I just showed, those are things that most people should stay away from. Now, existing laws take care of emergency situations. So if you go into an emergency room and a non-network provider sees you, which a lot of emergency room doctors are non-network providers, that's addressed by law. There's a new California law that went into effect about a year ago that non-network providers at network facilities. So there was always situations occurring where the anesthesiologist that you had made arrangements for your surgery was in network. They got tied up in the other operating room. They had to bring in another anesthesiologist to take care of your case, and that one was non-network. So there are California regulations that take care of those types of things now, but that still leaves wide areas for non-network providers to get access to people, or for you to use non-network providers. And remember that non-network providers can bill whatever they choose to bill. So in those examples of the bills and the EOBs that I showed, when interacting with members, a typical question is, well, the doctor billed me for $1,200 and you're saying it should have only been $400. Can't you pay more? Can't you pay more because he billed $1,200? And our response is, well, what if he had billed $5,000, or what if he had billed $10,000? In that example of the $104,000 surgery, what if that surgeon had billed $200,000? So we can't control, because we don't have a contract with that doctor, how much they bill. Doctors can bill whatever they want. We pay according to usual and customary charges. So we have records that show what those procedures cost in their market for that, and we pay according to those procedures. So addressing the non-participating provider issue. Ask the doctor's office if they're in network. That's the best way to do it. Although a lot of people are uncomfortable with asking, the doctor's offices are actually very accustomed to that question, and they'll say, yes, we're in the network. They're the ones that know. And verify, if you haven't been to the doctor or you're having a treatment with a new doctor, verify before you make your appointment or before you receive the treatment. Even if you look the doctor up on the insurance company web listing, those change daily, and by the time you get to that doctor's office, they may have decided that they're going out of network. And you say you looked it up on such and such a date, and you go to the doctor's office a week later and they've changed. If your network doctor sends you to have a test done, lab work, an X-ray, an MRI, ask or verify that it's being handled in network. This is a very common area where the referral goes out and it's handled in a non-network area. Always verify that your lab and MRI work is being handled in network. Now, some of this has been mitigated a little bit because a company called LabCorp has been buying every lab in the area, and they're contracted with most of the major carriers, Anthem, Blue Cross, Aetna, those kinds of things. So some of the labs, but it's very customary for a doctor that wants a quick result to send it to the lab across the hall instead of sending it out. And that lab across the hall might not be in network. So verify those things before it happens. And once again, the doctor's offices are glad to respond to those questions. Review these requirements with your dependents, especially college kids. So I have 2 college kids, And I know that they're tired of hearing about this. They don't go to the doctor very often, but they know that anytime the infrequent times that they go in, that they do ask for that, and it's drilled into their head that they have to go to network doctors. And then be particularly aware of specialists like orthopedic surgeons, psychiatrists, others in short supplies. They tend to move in and out of network very frequently, not so much with the primary care doctors, so verify beforehand. I just wanted to show a lab bill for a network lab. This is a standard cholesterol screening that about a third of our population has on an annual basis, anybody that's taking a statin drug, and you have to go in for this test. So you can see that this is LabCorp. Their standard rate is $642. The PPO discount is $569. So if this was a non-network lab, they probably would charge more than the $642, and you'd get stuck with the without that PPO discount. What we see, so we covered the things that we see that are common, the things that are percolating out there, the things that we see coming along. Experimental investigative procedures. 3D mammograms. Right now, they're classified as experimental. Probably in the near future, they may get more guidance around that, but a lot of people have bought these expensive 3D mammogram machines. Somebody comes in, they say, hey, we want you to have a 3D mammogram. The claim comes in and we say, hey, wait a minute, this person wasn't at high risk, they didn't need the 3D mammogram. The claim is being paid at the regular rate. Then there's genetic disease testings. So there's a lot of venture capital-based companies out there that are getting these genetic disease tests. So the doctor orders the test, and it's investigational or it's experimental, and these claims are getting denied for those reasons. And then all these new drug treatments. Check in to see if the doctor is trying something off-label. Also, with maintenance drugs, it's to your benefit financially to get your maintenance drugs through mail order pharmacies. It is a little inconvenient for the first prescription, but then after that it's much easier and it's a lot less expensive. And companies are starting to mandate that you do the mandatory mail pharmacy for maintenance drugs. Once again, there are issues around that where people go in for their drugs and they say, well, I have to get them through mail order. And then the whole thing with specialty drug costs. Specialty drug market has exploded. 5 years ago, we had less than 200 drugs on our specialty drug list. Now it's over 600, and all of these drugs are very expensive. If you see, for example, commercials, Humira, which is the #1 drug spent in the United States now, our cost on that drug is $1,250 a pen. They come in self-injectable pens. People take between 2 and 8 of those pens a month, so do the math on that. So these are expensive drugs, and when people see that hitting their out-of-pocket expenses, they sometimes have a little bit of take back, and so that's a developing area as more and more of these expensive specialty drugs come to market. Moving on to what we call a difficult situation that we run into often, not frequently, but often. So we'll get a call from a CPA firm, and they say, hey, one of our employees has a serious medical illness, and they started their course of treatment, and they were supposed to come back to work in a couple weeks, and things didn't go well, and now they've been out of work for X period of time, and we need to know how to handle that. So all group health plans that I'm aware of have what's called an actively at work provision. And that actively at work provision isn't meant to kick people off of health plans because they're not at work and they're sick. It's there to give eligibility to people coming on the plan. So it's for the employees that are working there, so that we don't have Cousin Elmer on the plan or somebody that's not working at the company on the plan. The people have to be actively at work. Well, then it also has on the other side of it is to determine when people aren't actively at work. So after people have exhausted with a serious medical condition, after they've exhausted their vacation pay, their sick pay, what do? And when are you going to change the employee's status from active to either inactive or terminated? And so those are the determinations. Once again, these can be very difficult situations. Everybody wants to treat the employee with compassion and fairness and do everything that's right because this person has a serious medical situation. But just realize going into this that there could be some difficult waters ahead, and nobody likes to deal with it, but it has to be dealt with. So our initial response when anybody calls us is, well, what is your firm's policy on this? And we recommend that no matter the size of the firm, and it doesn't have to be a greatly detailed document, but that you have a written policy on how you handle medical leave situations. Now, depending on the size of your firm, Family Medical Leave Act, the Federal Family Medical Leave Act may apply. But don't just adopt family medical leave if you don't have to. In other words, if your firm is 20 employees, don't just say, well, we comply with family medical leave, because there's a lot of things in that wouldn't necessarily apply to a serious medical condition that you would have to go along with that you're not aware of. So don't just adopt FLMA if you don't need to. Every medical situation is different, and the employees are going to be best served by a written guideline. You can subject yourself to discrimination problems if, for example, you have a long-term highly compensated employee that got sick last year and you did X for them, and then this year you have somebody else with less tenure or lower wages, and as soon as they ran out of vacation pay, you terminated them. So make sure that a written policy can help you with these things. And we also recommend that if you have a written policy or not, whenever one of these things starts happening, contact your attorney and have your attorney guide you through the process. It's that important. Nowadays, somebody contracting a serious medical condition, once again, all these situations are different, but depending on what it is, they might be subject to the disability, the Federal ADA Act, the Federal Disability Regulations. So there are areas with people that are disabled with certain diseases where it qualifies for that, and so you need to have an attorney or somebody that's skilled in this area guide you through that. And then your employee is going to be best served by being told the correct information the first time. So somebody's been out for a month or weeks or many months, and they want to know what's happening. And if you tell them, hey, well, we're going to continue paying you this, or we're going to do that, or we're going to make this arrangement, and then a couple more weeks or months go by and you have to change that based on either your policy or some other circumstance, you want to tell the employee, especially the one, as we talked about before, with compassion and fairness, you want to give them the right information up front, tell them how things are going to, what's going to transpire. They're going to be able they're going to be better off knowing one time right. So when you're developing this policy, your written policy, what are the considerations that you need to do that? Well, when are you going to stop paying an employee? Now, hourly people, that tends to be fairly apparent, but what about salaried people? If you had somebody on salary and they're coming back 15 hours a week, 20 hours a week, then they're missing a couple days for treatments, and then they're working 3 or 4 days in a row, then they can't work the 4th day because of fatigue or whatever it is. So figure out with your salaried and hourly people when you're going to stop paying the employee. If you stop paying the employee, if they're making monthly or weekly or paycheck contributions to their health plan, how are they going to pay their employee contributions to the plan if they're not getting payroll for you to do your payroll deduct? And then if the employee does transition over to COBRA, is the company going to make any contributions to COBRA? Some companies do, some companies don't. How long will you hold their position? This can be in the policy. If we're holding the position open for the person, then they're still active. If we're not holding the position open, then they're considered not active. One of the things that we think that companies should consider is long-term disability insurance. So even at minimum benefit levels, when somebody applies for long-term disability insurance, that can be, not always, but it can be a trigger for changing the employee's status. Now, I want everybody to know that just changing the employee status nobody is going to lose their health insurance. The seriously ill employee is not going to lose their health insurance. If their status is changed, they still have up to 3 years of COBRA or CalCOBRA. And under the Affordable Care Act, if they have no income coming in and you've changed their status, they've lost their group health insurance coverage, that they can possibly qualify for an Affordable Care Act subsidized health plan. And they could get their coverage for free without pre-existing conditions, or maybe just paying a small subsidized amount. So keeping them on the group health plan might not be the best financial arrangement for them. If they're making some significant contributions to those premiums, they may be able to get subsidized coverage elsewhere as a better arrangement for them. I mentioned that long-term disability insurance can be a really nice benefit for employees, but it can also aid in this difficult situation, because you can say to the employee, hey, we've got income sitting out there on long-term disability and you qualify, so this is how we transition you from being an active employee to being on long-term disability. And I just wanted to show these are our CalCPA Health disability rates, because a lot of people think that disability insurance is unaffordable. If you look in the far right-hand column, for most of these age groups, you multiply that by 12 on an annual benefit. I think that this is years and years ago when I bought my first individual disability policy. I remember the agent that sold it to me saying, how much do you pay to insure your car, and how much is your car worth? And I answered him, of course, and then he said, well, how much are you paying to insure your income flow? And in that situation, you can look at it that way, but then also from an employer standpoint, providing this to the employees, and then when we have situations where somebody gets a serious medical condition, it can fit into that overall policy program that we're talking about. So moving on to what I consider easily the biggest trend in health insurance. And the answer to that, of course, is health savings accounts. And I think the graph at the bottom shows why that I believe that there's nothing to compare with this trend. So this is a pure hockey stick graph that keeps escalating every year. The last 2 years, 2015 and 16, the number of accounts that have been opened up have gone up 20 and 22%. We now have over $41 billion in January of 2018 in HSA assets. So this is a big trend, and we don't see this stopping anytime soon unless the government were to significantly change the regulations. So why are these HSA plans in style now, or have been for the last few years? Well, there's a number of factors coming together. Under the Affordable Care Act, deductibles and out-of-pocket costs have boomed, increased significantly. And people are figuring out that they can pay out-of-pocket expenses, deductibles, with tax-preferred dollars through HSAs. Now, the other way to do that is with an FSA. But the ACA limited FSAs, flexible spending arrangements, and the flexible spending arrangement has an insurance component. So if you don't use the money in that particular year, you lose it. It is not a savings vehicle, and it's not portable. So the HSA plan doesn't have those components to it. It is a savings vehicle. It is portable with you, and you never lose your money in the HSA plan if you comply with the regulations, of course. So it allows you to save for current, future, and retirement health expenses. You can lower your current health insurance premiums. You take on greater risk by taking a higher deductible plan and then paying your out-of-pocket expenses out of your HSA plan. So prior to the Affordable Care Act, CPA firms were adopting HSA plans at about 10 times the general industry average. At CalCPA Health, we had the data to support that CPAs tend to get the triple tax benefits, and were adopting HSAs before the general population had caught on. We see everybody catching up with the increase in out-of-pocket expenses. So basically, if you've got a $1,500 deductible or a $2,000 deductible on a regular health plan, you would be better off, typically, being in an HSA plan because you can pay those deductible costs and the out-of-pocket costs with preferred tax dollars. So what are we going to talk about today with HSAs? Well, I'm going to cover the basics of setting up and using from the employer and employee standpoint. Now, on CalCPA Health's website, we have a guidebook, an HSA guidebook. It's around 200 pages. It goes into great detail. It's got a really nice index, so you can just look up the particular thing that you're looking for. So, we can't get into all those details today in this class. And then last fall, we ran another education class that went into great detail on plan designs, eligibility, contributions. Somebody comes on the plan in the mid-year, they make a maximum contribution, then their spouse comes on, then they go off. All those little nuances on HSA plans are covered in that prior CE class. It's also covered in the HSA guidebook. We're not going to get into that detail today. We're going to talk about, from a firm administration standpoint, firm management standpoint, how do we set these plans up and how do we use them. So the basics: an employee enrolls in a higher deductible plan, which is called a qualified high deductible plan. They pay for qualified medical expenses out of their HSA, and then there's the triple tax benefit. Now, California does not recognize HSAs, but the tax benefits at the federal level still, in my opinion or our opinion, make them worthwhile. Employees or employers can contribute to health savings accounts. No contributions are necessarily required, but the contributions are tax deductible. And then you can use the HSA funds at any time in the future. And of course, the big push here is also funds for health costs in retirement. It's estimated that if somebody was retiring at age 65 now, that you would need about $250,000 of medical expenses. Of course, it depends on how long you live. Medicare is not free. You have to pay Part B premiums. You have to probably buy a Part B supplement. You have to pay Part D premiums. You have out-of-pocket expenses with Medicare. All of that can be paid out of your HSA account. And then the HSA, of course, can accumulate your investment earnings. The money that's in the account is invested, and it accumulates those investment earnings tax-free. For an HSA plan, we have three components. We need an HSA administrator, a bank account or a custodian, and then a qualified deductible health plan. So CalCPA Health being a health insurer, we have qualified high deductible health plans. Now we're going to talk a little bit about standalone versus integrated HSA plans. When we talk about integrated, we're integrating the claims and eligibility between these three components above. I'll go into some details on those. So a qualified deductible health plan. It has to have at least a $1,300 deductible, $2,600 for family coverage. The regulations, the IRS calls it other than self-only coverage, so two people is a family. It cannot have any first dollar coverages. Now, when the Affordable Care Act came in, then they said, okay, well, if you go in for your annual checkup, that has to be paid by your plan. So then they modified the HSA regulations to say, okay, well, you can have first dollar coverages as long as it's within the federally mandated ACA benefits. But you can't have you can't have a drug plan, you can't have anything else that pays underneath your $1,300 or higher deductible. And then there's maximum out-of-pocket limits. I just want to mention down in the notes down below that the out-of-pocket limits are different for HSA plans than they are for regular health plans under the Affordable Care Act developed by the Department of Health and Human Services. Why they didn't make them the same, I guess that's just the difference in two government departments, but they are different. So when you buy a plan, you buy a qualified HSA plan, high deductible health plan, it'll comply with the out-of-pocket limits. And then the IRS alters these limits annually based on inflation. And here's a graph or a chart showing the HSA contribution limits, the deductibles and the maximums for 17 and 18, the amount of change. There is legislation in Washington, who knows if it'll go through, to double the contribution limits, make those up around $7,000 for an individual and $13,000 for a family. So how do we establish an HSA or get started? Well, you can get started at any time during the year, although most people start on January 1st, but don't let that stop you. You can get started at any time during the year, and if you get started, let's just say in November or October, you can make a full year's contribution to your plan in that year. There are some rules that apply. Basically, you have to be in for the entire next year. That's all covered in that prior class that I talked about. And then you have to be an eligible individual. So what is an eligible individual? Well, you've got to be an adult. You can't be dependent on somebody else's tax return, and you can't have other coverage. So you can't be on Medicare, Medicaid, VA plan, those kinds of things. You can be covered, auto policies have medical coverages on them. You can be covered by, for example, specific disease insurance. So when you talk, the common way to look at that is the AFLAC policies. Those are all okay. And you can have first dollar dental and vision coverages. Also, the question came up with wellness programs. So employers have wellness programs where they give a $50 benefit if you go walking at lunchtime, or if you stop smoking in a smoking cessation program, they give you some benefit. Those are all okay as long as they are not significant medical benefits and the government hasn't decided what significant is. But, if it's a few bucks, it's probably going to be okay. Another area that doesn't seem apparent is there's no income requirement for HSA. So you don't have to be working. It doesn't have to be through an employer sponsorship. You can be just an individual, a sole proprietor, or you can be unemployed and you can participate in an HSA plan. So let's talk about setting up the HSAs. So we just went through the qualified high deductible health plan part. Now we've got the HSA administrator and the bank account custodian. Most of the time, at least nowadays, those are one entity, and it's much easier to have them be one entity. There's some big names in this market, and I've got some examples down there. So Health Equity is a bank and an HSA administrator in one. They don't do regular banking. They are a bank, but they only do HSA banking. Mellon Bank is probably the biggest and oldest name in this market, and they operate an HSA plan or administrator called Benefit Wallet. HSA Bank is Webster Bank, Optum Bank. There's many more that are out there. Some are small, some are big. You look for integration services with payroll vendors and contributions reporting. So if you're with Paychex or ADP, they have standard coding to interact with most of these HSA administrators for payroll deductions and for transmitting contributions. Remember that the employee ultimately controls an HSA, so although an employer may sponsor an HSA, they may set it up with a particular administrator, the employee can decide which HSA administrator they want to use. So if you hire an employee and they had an account at Mellon Bank with Benefit Wallet and you're with Health Equity, they can continue to maintain that. Now, you can also, as the employer, say, well, we're only making contributions to the one that we're electronically hooked up with. We're not making them to the other. You can do that if you'd like to. It's usually advantageous to have, if you're an employee, to have your account with the HSA administrator or bank that your employer is working with, even if that entails moving it over at some point in time. So how do you choose which of these to go with? Well, you want to look at the fees and the ease of use and the investment options that you're going to be running into here. Fees can vary greatly. And fees can be bundled and unbundled. So I'll talk about the bundled ones, which are I think most popular. So for example, our arrangement with Health Equity is $2.95 a month, and that includes all of the services. Other bundled rates can go up $9 or even higher a month, but those are competitive rates. Then there's unbundled, where you pay for every transaction. So I've got some examples here where you pay an annual fee, you'd pay for a debit card, you pay every time the debit card is swiped, and then you pay per checks. And then usually investment fees, whether it's bundled or unbundled, are all handled separately. I just want to show another example of an unbundled fee and how they charge and how these things can add up. So I think our recommendation would be to look at the bundled ones. Spending $36 or $45 or $48 a year to have an HSA account administered seems like a pretty good deal to us. And then up at the top there, you can see the custodial fee. That's for investments. So they're charging 62 cents per thousand on a quarterly basis. Once again, I don't think that that's an exorbitant amount of money, but those fees can greatly vary, and you need to look at those. And we'll get into the investment choices. So I just grabbed some. So HSA Bank, they allow trades with Ameritrade's actual fees. They charge a $24 annual fee. Health Equity has 26 mutual funds. They charge 0.33%, so that's 0.003 per, because that's a percentage. So once again, they charge 1/3% per year approximately to manage that. Health Savings Administrators, they have a choice of 115 mutual funds. They charge the same as what we just looked at on that last one. They charge the $625 quarterly. Remember that you cannot pay your medical expenses directly from the investment account. So when you set this up, you're going to have a bank account and then you have an investment account, and you move the money from your bank account in the investment account. You pay your health costs out of the bank account. So if you have $20,000 in your investment account and you have $400 in your bank account, and you have a $1,000 medical bill you want to pay, you need to move $600 back to the bank account and then pay it out of the bank account. That all happens electronically, but you can't pay directly from the investment side. So with automated administration, now HSA administration's come a long way. 10 or 12 years ago, all this was handled piecemeal, and it was an administrative burden on employers and employees. So it's come a long way. Employer enrollment and eligibility, the medical plan is integrated with the HSA administrator. So what I mean by that, for example, when somebody reports eligibility to us, so they add somebody to a health plan or they take somebody off their health plan, or they add a dependent, change a dependent, we automatically shoot that over to the HSA administrator for the employer. That's an integrated eligibility feed. And then also on the claim side, we shoot the claims over to the HSA administrator. So somebody's enrolled in an HSA plan, we shoot their claims over to the HSA administrator so that they can handle them there. Where once again, in the old days, they all had to be either provided by mail or manually provided in some manner to the HSA administrator. So I want to go into some screenshots just to show you what. Now, so in this one, and by the way, these are all going to be health equities that we're looking at because that's the one that I have access to. So you can see here it says in addition to payroll deductions, you can set up an EFT to make contributions to your account. So you set up your checking account to your HSA account, and you can go in and make your contributions whenever you'd like to do that outside of payroll. You got to watch doing that though to make sure that you don't go over any limits. Usually the payroll has limits on the contributions, so that if you cross a threshold, it won't allow you to contribute anymore. But these are modern options. I want to take a look here at the claims and payments. So you can see the options here. You can view claims, add claims. All of this is right at your desktop. Now we're looking at some claim detail. I've selected here. And you can see the first claim has been paid. The second one has a partial amount due, and the third one has the full amount due. If you go over to that resolve button and you clicked on that, you could make, right from your screen, you can pay the provider, you could pay the provider a partial amount, you could pay him the full amount. If let's just say that you had already paid the provider in some other method, or the provider was writing the amount off, you could wipe that amount off in your HSA account so that it doesn't show. So you can handle everything right here on your desktop efficiently without manually writing checks, without having to keep other paper records to reconcile your account. Once again, some more screenshot here is just showing you the integrated capabilities that are available. Here we're looking at the interest rates, the transaction histories, the investments. So everything is, all your statements, everything is available to you right at your desktop. So as I said, the biggest trend in health insurance is HSAs. We recommend that all employers and employees evaluate if HSA plans are for them. All health costs, out-of-pockets, deductibles, retirement premiums, they're going to continue to escalate. We don't see any change in that. And the burden is being placed on the employees for this. And so HSAs can be the best solution for that area. Another trend that we see is that that wellness programs, at least from an ROI standpoint, they don't work all that well. Employees move, and the return on investment is usually much longer term than that. High risk employees tend not to comply. The financial carrots aren't big enough to get people to comply, and then a lot of the costs are related to the dependents, and they don't comply or are not part of the program. So what we see a current trend is in medical decision support, helping employees make better medical decisions. And this is particularly important, and it fits right in with the HSA plans where employees are taking a much bigger chunk of the risk. So here's some data that we have from one of our vendors. So the takeaway here is that people are looking for medical information, and they are looking for help in that area. The statistic there in the middle, 88% of the patients who go to the Mayo Clinic for a second opinion get a different diagnosis than their original. Well, first of all, if you're going to the Mayo Clinic for a second opinion, you may have something a little bit more exotic to start with, but still, it's a telling tale here. And then down at the bottom is that 92% of the people want to talk to somebody on the phone. They don't want to web chat. They don't want to search for themselves. They want to talk to somebody that knows what they're doing, that can advise them. So what we're seeing health plans and employers providing are teams of experts in certain areas. And this isn't a 24-hour nurse hotline where you call up and say, my kid's got a fever, should I take him to the emergency room? This is where you can call in and say, whether it's mundane or serious, my doctors told me I have this. What should I be doing? Where are the best doctors? What's the best treatment patterns? Things like, and I've got down at the bottom there, surgery options, knee and hip replacements. Well, a lot of people are getting knee and hip replacements, and there's a lot of decisions that need to be made around that your doctor helps you with, but you'd still like to get some expert opinions. What devices am I going to have installed? When should I have it done? All those things people would like to have help in. At CalCPA Help, we address these situations. We've recently rolled out a program where we give all of our members access to these expert panels of people to ask these questions. And I think this is a big trend. As people take more and more responsibility in HSA plans for their medical care, from a dollar standpoint, they want this information. So let me move on to the ever-changing Obamacare regulations that we're over 5 years. Well, the law was passed in 2010, but the implementations really started in 2014. The big change coming for 2018 is that under the Affordable Care Act, they specify what we call age relativities. So the federal government publishes the rate that so if we charge a 24-year-old $100, every insurance company in the country charges a 25-year-old, the 105, let's say, okay, and currently 20-year-olds are charged, and let me use my example again, 100. 21s would be 57.5%. That gap was specified in the Affordable Care Act. Actually, it was specified by the Department of Health Insurance Services. They interpreted the Affordable Care Act and published that rate. So this was always a shock for parents who had a child that went from 20 to 21. They got a 57% rate increase. And for example, we try to work people through that as best we can by notifying them of that, but that's every insurance company in the country. Nobody can change that. Well, in 2018, the government is trying to fix this situation. Of course, when they fix it, they're going to, I think, create a lot of other problems. But in 2018, they're going to alter this age relativity curve, and they're going to make 0 to 14-year-olds, they're going to increase those rates 20%, 20.5%. And then from 15 to 20, they're going to stagger or incrementally increase to get to that 57.5% increase for the 21-year-olds. So what they're going to do is they're going to increase everybody's rates under 20 to bridge that big gap of going from 20 to 21, and also increase all children's rates. Now, I think the irony here is, of course, is that from an actuarial standpoint, teenagers cost less than younger children. And so this, of course, in the old days, we used to just charge all children the same no matter how old they were. But certainly, say 0 to 5-year-olds cost more than, say, 16-year-olds on health insurance plans. but this is going to reverse that and charge more for those teenagers. So let me show you what this looks like in a chart. And so here are the 0 to 14-year-olds getting a 20% increase in 2018 from their 2017, all things being equal. So if the kid was being charged $100 in 2017, in 2018, same plan, same benefits, they would be charged $120.50. And then here's the additional or the incremental increases for 14 or for 15, 16 up through 21-year-olds, and then the cumulative increase. So if somebody is age 19 this year and they were 18 last year, well, at 18 they were at the 100%, right? They're going to get a 48.2 this year as this gets implemented. So those are how the big numbers work. This is prescribed by the federal government. California has adopted these regulations. Every insurance company in the state or in the country will have to do this. So it's not just any way around. Once again, this is for small employers up to 100 employees. And then we're going to finish up with what we call the ever-changing regulations, Obamacare Sustainability. A lot of people say that Obamacare is imploding. What does that mean? What does it mean that it's imploding, or the sustainability of this program in the long run? Well, the data is showing the opposite of what the proponents of the Affordable Care Act initially predicted. So Medicare costs continue to escalate. Congress had set funding limits, funding ceilings on Medicare. And some of that was in the Affordable Care Act, some of it was passed years before the Affordable Care Act, and they've had to act to increase funding every few years because they can't control the costs, they can't control the utilization in Medicare. Commercial insurance. The data that we have that was just released in May from the 39 healthcare.gov states is that the average premiums from 2014 to 17 have gone up 105%. And as I recall, Iowa was a state that was right on that mean at 100, or that average at 105. The median was 108. 16 states were under 105%. 20 states were above. 3 states were above 200%. So if you were a solo practitioner in the state of Iowa, your rates have gone up 105% in the last since 2014. That's not sustainable. People that are receiving subsidies, the federal government is picking up that amount of money. Because under the Affordable Care Act, if you're getting a subsidy, it's based on your income. You pay a fixed amount based on your income. When the health insurance premiums go up, the federal government picks up that difference. So those costs are exploding, and that's where the unsustainability comes in. And then Medicaid and Medi-Cal. Medi-Cal is Medicaid here in California. Also in June, it was just released that since Obamacare's inception in 2014, that emergency room visits are up 44%. Now the promise was that if people had access to health care, that they would go to primary care doctors for their care. As it turns out, the data appears to be showing that people are going to the emergency room. And I'll talk about why that's happening, but California in the current budget, at least the one the drafts that they released here recently, they're putting another $700 million of Medi-Cal funding into the budget because it's running out of money. So, why is all this going on? Well, the underlying cost of medical care, it's about utilization. All right, so the Affordable Care Act did not really have utilization controls in there. There's very little utilization control in the Medicare program. In the healthcare.gov, there were utilization controls or utilization problems with allowing people on and off the plan. Some of that has been trying to be fixed, but the cost explosion relates to utilization. Hospital charges have been exploding. Procedural charges, RX drug costs going through the roof, and doctor and specialist charges. So all of these things are increasing the underlying cost of medical care. And remember, and of course I have a point of view on this from the insurance company standpoint, is that insurance companies have been locked into expense and profit numbers even before the Affordable Care Act came into place. And so the percentages that they charge have remained stagnant, but then again, we've had a 105% increase. All of that increase is medical costs and utilization costs. It's not health insurance company costs because theirs have been fixed during that time. So what will happen with Obamacare in the future? Without changes that affect utilization, Obamacare costs will continue to escalate. For federal and state governments, the costs will continue to go higher. Deficits or higher taxes will be the results, and individuals not receiving subsidies are bearing the brunt of those increases. So as I mentioned, questions or comments, feel free to contact CalCPA Health about any question for you, your firm, or for one of your clients. Here's my contact information. You can find us on the web, and feel free to use us as a resource for you and your business.